Up next is a Department of Health special session. To open this session, please welcome Dr. Clarito Cairo, Program Manager of the DOH Philippine Cancer Prevention and Control, and is currently an Occupational Safety and Health Practitioner at the Department of Health Central Office.
Good evening, ladies and gentlemen. Our next session is a panel discussion entitled The Cancer Control Program of Asian Countries, Learning from Experiences and Best Practices. Our first panel speaker is Professor Suhartati Gondowarjo, a senior consultant at the Department of Radiotherapy at Cipto Mangunkusumo National General Hospital in Jakarta, Indonesia. She is the chairperson of the National Cancer Control Committee, president of the Federation of Asian Organizations for Radiation Oncology, president of the Indonesian Radiation Oncology Society, and national project coordinator for several IAEA projects. Our second panel speaker is Professor Ekapop Sirachanan, AOS board member and president of the Thai Society of Clinical Oncology. He is an associate professor at the Oncology Unit of the Department of Medicine in Mahidol University and the chair of Ramatiburi Comprehensive Cancer Center. Our third panel speaker is Professor Sanjeev Misra, AOS counselor and director and CEO of All India Institute of Medical Sciences in Jodhpur, India. He is a professor of surgical oncology at King George's University, sectional editor in oncology of the Indian Journal of Surgery, associate editor of Indian Journal of Surgical Oncology, president of the Indian Association of Surgical Oncology, a founder member of Indian Breast Group and Indian Liver Group, and member of the Board of Trustees of the Jodhpur Initiative. Our fourth panel speaker is Dr. Tung Bui Duk, AOS counselor and supervisor of the Ho Chi Minh City Cancer Registry. He is a surgeon at the Department of Breast Cancer at Ho Chi Minh City Cancer Hospital, voting member of the International Association of Cancer Registries, and member of the Association of UICC Fellows. Our last panel speaker is Professor Dong Yung No, AOS Advisory Board member and past president of APFOCC and APCC. He is the chief of the Breast Care Center and Laboratory of Breast Cancer Biology in Cancer Research Institute at Seoul National University. He's also the principal investigator of the Minister for Health, Welfare and Family Affairs funded Translational Research Organization in Cancer Project. Ladies and gentlemen, please welcome our distinguished panel speakers, Professor Suhartati Gondowarjo, Ekapop Sirachanan, Sanjeev Misra, Tung Buiduk, and Dong Yung No.
Good afternoon, everybody. It's a great honor for me to be invited for this very special event, and I would like to extend my appreciation and thanks to AOS committees for arranging this wonderful event. The world is currently under the high pressure in meeting the demands, along with the increasing number of people living with cancer globally. Considering the potential burden of the problem, NCDs were then included in the 2030 SDGs. We know that at least 400 million people have no basic healthcare. Every 2 seconds, someone aged 30 to 70 years old dies prematurely from the NCDs included cancer. And the United Nations under the SDGs has also tried to address cancer-related premature mortality by 2030, reduced 1/3 premature mortality from NCDs through prevention treatment, promote mental health and well-being. Now the rank of cancer incidence globally is shift from number 4, 2007 to number 2 in 2017. The IARC has predicted that the burden of cancer will continue to increase to 29.4 million new cases in 2040 from 18.1 million in 2018, and analyzed that 1 in 6 deaths in world was caused by cancer. Lung and breast cancer are the most prevalent cancer in male and female. This implies that a new cancer is diagnosed every 1 second, and every 2 seconds someone dies from cancer. Nearly 70% of the global cancer burden occurred in low and middle income countries. Asia is a big continent. consists of 51 countries and 60 of the world populations. With diversity in income, number of population, as well as the HDIs. 2014, Radiation Oncology Societies around Asia gathered to establish the Federation of Asian Organization for Radiation Oncology, a non-profit and scientific organization with intent to function as the Federation of Radiation Oncology Society in the region. Has 14 member states and have more than 50% of the world population and 84% of Asian population. This showed us increased rank of cancer rate in some area in Asia Pacific from number 6 to in 2010 to number 2 in 2017. And we know that the highest incidence of cancer is in Asia, 48.4%, and mortality rate for 57.3% globally. National Cancer Control requires a comprehensive approach based on cancer journey from the prevention to end of life, and it requires unique activities and supporting policy. Effective planning of cancer control requires contextualization of the country situation and must be integrated multi-sectoral and interdisciplinary. Early detection is one of the most efficient investment in cancer control and must be linked to access to prompt, affordable, and quality of treatment. It's involved 3 steps, so-called the awareness and assessing care. The second step is the clinical evaluation for diagnostic and staging, and the final step is access to treatment. Early diagnosis is measured by interval of time. Delay may occur along the entire pathway. Most delay occur in awareness and assessing care phase with a median of 1.2 months, and the worst is in low middle income countries with a median of 6.8 months. The NCCP is a public health program designed to reduce the number of cancer cases and death and to improve the quality of life of the patient. It consists of all the intervention of cancer journey from the prevention to the survivorship and the palliative care, and must be framed by the health system supported by effective financing strategies, continuously observed by monitoring system, and equipped with the quality management. The Economist Intelligence Unit in 2019 developed the Index of Cancer Preparedness that explore cancer preparedness through policy and planning, care delivery, and health system and governance. And this is one of the results of that plan should be based on systematic situational analysis and the burden of cancer and the resource and capacity available to inform policy and define the next step that are the priority setting and formulation of the cancer control plan. Without priority and the realistic goals, NCCP will result in a little impact. Implementation should be based on the evaluation of the existing intervention to assess the feasibility and sustainability of the program. Scaling up is the final step when the initial evaluation showed positive result conducted in step and with due consideration of financial needs, coupled with the monitoring and evaluating to ensure the quality and safety of delivery of care. Indonesia has also undergoing in epidemiological transition also from communicable disease to both communicable and NCD, so-called the double burden of the disease. The latest data showed that the prevalence of cancer increased from 1.4 to 1.8 2013-2018, with the breast and cervical cancer placed in the highest incidence of cancer, the highest incidence. The cancer incidence is predicted to increase 70% and 78% of cancer death in 2040, with the financing reaching the 275 million US dollar on the national health insurance from 103 million US dollar in 2013. Based on the NHI data, the catastrophic disease takes 20% of the total annual cost of the national insurance. Cancer financing also continues to be ranked in the top 3 of that. NCCC, National Cancer Control Committee, began in 2014, visiting together government, non-government, professional society, try together to formulate the concept of NCCC. And at the end of 2014, it is signed as the NCCC decree by the Ministry of Health. Then first we begin formulated the logical matrix, root analysis, all possible factors that cause of cancer condition in the countries, high morbidity, high mortality, and high cost. Then we got all those factors, then put it all as a 13 goals in our NCCP strategic planning. Each goal has their own action plan and KPI. This is an example how we do the needs analysis for radiotherapy services within the countries based on IEA formula. Then we make a plan to fulfill the gap. That's the roadmap. And to completing the radiotherapy service, it should be parallel with the National Cancer Control Program in general. Indonesia strongly committed to fighting against cancer. So the government requests the IEA to conduct an integrated mission of program of action for cancer therapy, so-called the IMPACT program, to access the country cancer control capacities and recommend appropriate measures. The IMPACT mission first done in 2010, and in 2018, the review was requested by the Ministry of Health to access progress since 2010, as well as to identify remaining gap and needs to continue to strategically comprehensive cancer control. IMPACT gave several recommendations and be considered for inclusion in the next NCCP 2019, which will be linked with the interministerial National Action Plan for NCDs. Also, we incorporated the impact review recommendation into the medium-term development plan 2020-2024, residential instruction community campaign for healthy living, so-called the GERMAS, and also the government regulation year 2018 about minimal standard service, and Ministry of Health program, Healthy Indonesians through the Family Approach program. In 2019, under the WHO and WHO shares guidance, the technical help, the NCCC developed the second National Action Plan 2020-2024. MUH intend to develop it more focused and pragmatic. Firstly, the program may prioritize the three common cancer: breast, cervical, and leukemia in children. Since that, secondly, the program may optimize cancer program at district level in this decentralized system, and then will be expanded to all district and province in Indonesia. Thirdly, the program may combine common measures such as health promotion, palliative care, and specific treatment program for breast, cervical cancer, and leukemia. It is in line with the National Action Plan for Cancer Control 2020-2024. It developed to meet 4 outcomes and carry out by the 5 pillars. First is the health promotion and primary prevention. Second is cancer registries. Third is priority cancer treatment. Fourth is palliative care. And fifth is secondary prevention, and supported by the good governance and leadership. It is expected to achieve first, practice in 9 key priority behavior. And the second is the fulfill of minimum standard of the health services, particularly for the VIE test and CBA at district level. And the third is provision of quality assured cancer service at primary care and hospital in line with the guidance and accreditation. And the last is evidence-based effective governance. A good analogy for this undertaking is like a hourglass with the higher proportion of health promotion and primary prevention and palliative care than treatment. So the difference between communicable disease versus non-communicable disease, we need strong policies and political ways to decrease the incidence and burden of non-NCDs, especially in cancer. Then the effort also requires sustainable advocacy involving all key stakeholders and multi-sectorals engaged to the main purposes, which is to reduce the mortality and morbidity case of cancer in Indonesia. As a take-home message, this 10 key action. Thank you very much.
Good afternoon, everybody. My name is Associate Professor Ekapop Sivachanan. I'm the President of Thai Society of Clinical Oncology, or TSCO. Today I'm gonna give you the talk about the Cancer Control Program of Thailand, learning from experience and best practice. As you may know, Thailand is in the group of upper and middle income economies defined by World Bank in the same group as Malaysia, Indonesia, and China. This is the mortality rate per 100,000 population of showing 5 major causes of death in Thailand. You can see that cancer is the leading cause of death in Thailand since 1999, so it's almost 21 years. The mortality rate is higher than accident or heart disease and hypertension and stroke. So the estimated number of new cancer cases in Thailand in 2014 was around 60,000 in men and 63,000 in women, corresponding to age standardized rate of 143.8 and 134.2 per 100,000 respectively. So in Thailand, we collect the data of cancer patient around the country, and it was published in the book Cancer in Thailand. The latest version was volume 8 in 2010 and 2012. So this is the incidence of cancer in Thailand. The most common cancer in Thailand is liver and bile duct that include hepatocellular carcinoma and cholangiocarcinoma. Because in the northeastern parts of Thailand, the incidence of cholangiocarcinoma is highest incident in the world. And hepatocellular carcinoma is common because of hepatitis B infection. The second most common cancer is lung cancer and colon cancer, prostate cancer, respectively, in male. For female, breast cancer is the most common cancer, and the second most common cancer was cervical cancer, and also liver and bile duct cancer or cholangiocarcinoma, also common in women in Thailand. So for the cancer control strategy in the country include primary prevention, secondary prevention, and treatment. Primary prevention that we start already, as shown in the slide. Vaccination, especially for hepatitis B infection, and also HPV or human papilloma virus. Anti-smoking campaign was started many years ago and try to control or reduce the use of cigarette smoking in Thailand in adult and also in the young adult, and also alcohol consumption control, especially in special holidays event. Opisthochis vivarium control, because Opisthochis vivarium is the major cause of cholangiocarcinoma. So the campaign for Opisthochis vivarium control has been started for many years to control the cholangiocarcinoma, and also as the same as many cancer in the world, helps lifestyle promotion was started already. For the hepatitis B vaccination, every infant in Thailand must receive hepatitis B vaccination for hepatocellular carcinoma prevention. This program was the same program that show the efficacy to prevent hepatitis, like in the many countries, like in Taiwan, that show that the vaccination can reduce the incidence of hepatocellular carcinoma in adults. And also for tobacco control, this is cigarette package in Thailand, that the law, by the law, the cigarette packet must show the picture of the cancer patient on the package to warn the smoker that cigarette smoking can cause like a package and can cause esophageal cancer like in the right package. So this will warn and make the cigarette smoker to think again for the smoking of cigarette, or may bring them to stop cigarette smoking. For the campaign of cholangiocarcinoma, we know that Opisthochis viverni, a parasite which stay in the fish, can cause the cholangiocarcinoma. So the project Look Free Thailand to educate the patient to avoid eating raw fish, and then they will prevent cholangiocarcinoma in most of the patient, especially in the northeastern part of Thailand. And also for the early detection or secondary prevention, there's some screening program in Thailand also, like a program for screening for cervical cancer. We do pap smear in people aged 30 to 60 every 5 years. Screening for breast cancer, breast cell examination in people aged 30 to 70, and clinical breast examination on the woman aged 40 to 70 years with mammogram. And also program for screening colorectal cancer. We do fecal immunohistochemical tests in the people aged 50 to 70 years every 2 years. For the treatment of cancer, health insurance schema of the cancer patient in Thailand can be divided into 3 groups of schema, like show in the slide: Civil Servant Medical Benefit CSMBS, Social Security schema, and universal coverage. Most of the patients use universal coverage, around 75%, and that means that the only one group, CSMBS, can reimburse for original chemotherapy or targeted therapy and immunotherapy. Just only a small group of the patient. Most of them could not access to the original or targeted immunotherapy. They can access to only generic chemotherapy. Anyway, we have some drug that use compulsory licensing drug that can be used into every schema. So the problem will be that most of the patient could not access to the effective treatment of cancer. For the society, Thai Society of Clinical Oncology, or TSCO, our objectives to train medical oncologists to work all around the country. Every medical oncologist in the country are member of our society, TSCO. And right now, we have 279 medical oncologists around the country, and we can train medical oncologists around 19 to 20 new oncologists per year from 10 training centers. And we plan to train more and more medical oncologists to serve the country. You can see the map of Thailand on the left side, that in the blue province, that is province that have medical oncologists working in the province. Anyway, in the yellow province, there's some lacking of medical oncologists, so we need that in the future more medical oncologists can distribute to all over the country, so the cancer patient can access to the treatment more effectively. Thank you.
So I'll be talking about the experience of cancer care and control program from India, and briefly I'll be covering about what we have done. So the government of India launched the National Cancer Control Program in 1975 with the objectives of primary prevention, early detection, augmentation of treatment facilities, pain control, and palliative care. There have been several revisions, the last revision being in 2005, where also it was added that there were a lot of geographical imbalances in the cancer care, and that needed to be corrected in the National Cancer Control Program. So first, we needed a good data to start a National Cancer Control Program. So the government initiated the National Network of Cancer Registries in 1982, so that we could have good, robust data for this purpose. In 1982, starting from a single cancer registry in Mumbai, now we have got 36 population-based cancer registries, of which 33 are urban, 3 rural, and 236 hospital-based cancer registries. The government later also initiated a program of an atlas of cancer in India for this data. What we have learned that, as we know that Asia contributes to nearly 50% of the world cancer incidence, and India contributed 12% of the Asian burden and 6% of the world incidence of cancer. And if you look at the cancers, if you look at the incidence per year, it's 1.1 million new cases per year. At any given time, nearly 2.25 million people are suffering from the disease. What we learned from this was that the cancer in India was a decade younger than the Western population, and majority, nearly 3/4 of the people were having advanced stage. Therefore, there was a very high mortality to incidence ratio was very high. Again, if you look at the variations of the cancer across different parts of the country, because India is a nation within a nation, if the rural part, the cancer incidence is much less at 41 per 100,000. And in the Northeast, it's very high at 270 per 100,000. While in Delhi, it's around 150 per 100,000 population is the incidence of new cases. And if you look at the what are the different cancers in the part of the country, head and neck cancers are common all across the country because of the tobacco consumption. But in the north, it's the gallbladder cancer is common in the Indo-Gangetic belt. In the northeast, it's the nasopharynx and the esophagus. In south, we have also got gastric cancer is common. There is an increasing trend of cancer, and we expect around 2 million people suffering every year, new patients by 2040. And women tend to be having more prone to cancer, more cancer incidence than the men. This is because has been attributed to increased urbanization, the emergence of the tobacco, environmental factors, change in the lifestyles, and a better capture of the data with this. If there's also been a major change in the trend of cancer, where cervical cancer was the commonest cancer in 1990, but in 2016 it was breast cancer, and tobacco-related cancers were again very common as before, and lung cancer also moved up the list. And this is again because of tobacco, environmental factors, pollution, and the decrease in the cervical cancer is because of better reproductive hygiene. Now, the objective of the cancer control program prevention, it's most cost effective. Tobacco control is still as the top for the primary prevention, and smokeless tobacco also contributes to a major part of cancer in the country besides smoking. Nearly 1/3 of all our cancers are because of tobacco, and nearly 50% of our cancers in men are because of tobacco consumption. But we have done well as far as the campaign against tobacco goes. We are among the top nations which are following the mass campaign against tobacco, and starting from different legislatures to be made against tobacco. If we see, we have made slow progress, but yes, we have made progress in this. But yes, more is to be done, and slowly it's going to bear dividends and have its positive effects seen. We've also included the effects of tobacco on health and in the school chapters, because a lot of teenagers pick up the habit. For early diagnosis, we don't have an active screening program because it's not cost effective, but cervix, breast, and oral cancers are very amenable to early detection. And if you look at it, the government has launched a program for non-communicable diseases, which has cancer, diabetes, cardiovascular diseases, and stroke. And in this, they've used added breast, cervix, and cervical cancer for a door-to-door screening and education. So they've trained the local healthcare workers to screen breast, oral, and cervical cancers once in 5 years by clinical breast examination, oral visual examination, and visual inspection with acetic acid. And the local healthcare workers, if they find anything abnormal and they think it's suspicious for cancer, refer it to a higher center. And they're also involved in education about healthy lifestyle to these people. If you look at the infrastructure for treatment, starting from 5 regional cancer centers in 1975, now there are 27 regional cancer centers besides a lot of institutions of national importance which are involved in cancer care, and also the private hospitals which are giving cancer care across the country. And if you look at the treatment facilities, our radiation machines number has gone up in the country, but still we are nearly 1,200 machines short as far as the atomic energy guidelines, which we hope to overcome soon. Coming to the trained manpower, we've started structured training in surgical oncology, medical oncology, radiation, and to have enough trained manpower so that enough workforce is available. And we also have specialty and fellowship training programs to provide cancer care across the country. Palliative care and pain relief, yes, remains a major problem, and new MD programs in palliative care have also been initiated for better palliative care in the country. 82% have no health protection in our country, and nearly 60 to 70 million people fall into poverty because of this. The government launched a program of Ayushman Bharat, where they were giving 0.5 billion Indian rupees per year to each family. That is, they had identified nearly 100 million families, and they were offering this. So this is a scheme which will be a game changer for cancer management and overall health improvement in the country. And there are standard management guidelines which have been advocated so that there is standardization of healthcare in the country, especially in the remote parts of the country. So if you look at our cancer control program, starting from the policy in 75 to generating, measuring the problem and generating data in 82 to control of the risk factors, then infrastructure and evidence-based guidelines. So we have done well, but yes, cancer care continues to evolve, and the cancer control program also involves, and it's still an unfinished agenda. Continuous efforts are needed at every level, and tobacco control continues to be a top priority, and strategies which work for India need to be evolved and are being worked on. And thank you again for this patient hearing, and thank you.
Good evening. This is Dr. Corazon Ngelangel, AOS 2020 Manila, Secretary General and President of the Philippine Cancer Society. I will be giving the talk and the slides of Dr. Tong Wedok, AOS Counselor, Supervisor Ho Chi Minh City Cancer Registry, on the topic Cancer Control in Vietnam, focusing on cancer registry. Vietnam has a population of 93.7 million, predominantly rural, life expectancy 73 years old, number of doctors and beds compared to the population, it's not really that much. GDP per capita is $2,326 US dollars. The organization of the health sector in Vietnam is similar to other countries. Topmost government, Ministry of Health, followed by city, provinces committees looking at health services, provincial hospitals, preventive health facilities, medical school, production, and health service provision units. Next are the district committees looking at district health centers, and then commune committees looking at communal health centers. Vietnam has NCD as the topmost diseases and on an increasing trend compared to communicable diseases, accidents, injury, and poisoning. NCDs are the leading causes of deaths in Vietnam. 7 out of 10 deaths are caused by NCDs, and if you notice, cancer is the second leading NCD. Number of new cases, 2018, both sexes, all ages. Top cancer sites are liver, lung, stomach, breast, and colorectum. By males, top cancer sites are liver, lung, stomach, colorectum, nasopharynx. Among females, breast, colorectum, lung, stomach, and liver. If we compare this to world age standardized incidence rates by sex and incidence and mortalities, top cancers, liver, lung, and stomach are the main culprits. Comparing cancer patterns, Vietnam versus Southeastern Asia, you notice that liver stands out in Vietnam and breast is the predominant cancer in Southeast Asia. Compare the cancer patterns in Vietnam versus developed regions. You notice liver and stomach standing out in Vietnam. And in developed countries, you notice breast and prostate as the most common cancer sites. And in Vietnam, you also note that prostate is not really that much. Looking at risk factors in females, age group 25 to 64, comparing year 2010, 2015 in Vietnam, you notice that decreases in smoking and limited vegetable intake happens in 2015, particularly in limited vegetable intake. Taking the males, same group age, comparing 2010 and 2015 years, you add on limited physical activity and raised total cholesterol improvement. All the data that have been presented could not have been possible without the Vietnam population-based cancer registry. Population-based cancer registries provide the data-driven foundation for cancer control efforts. Cancer registries analyze the data collected and share the answers to these questions with other groups, like state comprehensive cancer control coalitions, which work to prevent cancer. These groups may find that some people aren't getting cancer screening tests or they're making choices that raise their chance of getting cancer. The data may also show that certain groups of people are getting cancer more than others. Cancer control groups and advocates work to address the problems identified. Then they look to cancer registries for new information to help them know if their solutions are working. The Prime Minister of Vietnam approved the strategy for NCDs 2015-2025, and this included the National Cancer Control Program. The objectives are to reduce cancer incidence and mortality rate and to improve the quality of life for patients with cancer. The components are raising awareness for the people, prevention, including vaccination, screening, early detection, capacity building for healthcare staffs in the community and in the hospitals, in the health facilities, and improving cancer registry. There is a cancer network in Vietnam, and there are 8 major oncology hospitals scattered across the country. There are 71 department centers belonging to the general specialized hospitals at the provinces centers. There are 54 out of 63 provinces with a Center Department of Oncology, and this has been ongoing since less than 5 years now, still in the process of capacity building and equipment infrastructure maximization. Results of the initiation of the National Cancer Control Program in Vietnam, particularly in health communication campaign as the initial salvo in any national cancer control program, there is an improvement in knowledge of cancer and in satisfaction with cancer information. There is also ongoing implementation of the screening and early diagnosis program, particularly in breast, cervix, colorectal, and oral cancer. In coming up with screening programs, make sure that this is covered by health insurance and there is adequate follow-up after screening, and this should be under an organized screening program, and the focus of screening would be high-risk people, particularly in the early implementation of the organized screening program. In Vietnam, the population-based cancer registry has its main offices in Hanoi and Ho Chi Minh, and these two major centers are supported by cancer registry centers in Tai Nguyen, Haiphong, San Hoa Hu, Da Nang, Can Thu, Kian Giang, and all of them use a uniform cancer registry form formulated from the International Agency Research on Cancer, WHO, based in Lyon, France. And this is also the form used by all the IARC covered population-based cancer registry in the world. IARC WHO lends supports to the Vietnam Cancer Registry as it does in all other IARC covered population-based cancer registries in the world. There is a global initiative for cancer registry development partners task force that often visit IARC covered population-based cancer registry countries, and this is also in Vietnam, and recommendations are strengthen registry data management in CANREC. CANREC is the IARC WHO population-based cancer registry software used in IARC-covered PBCR in the world. Other recommendations are National Cancer Staging Committee should be put up. There should be peer review, specific training in data assessment and analysis, designed IT professional, and particularly there should be stable budget for operating PBCRs for long-term sustainability. Vietnam National Cancer Control Program and Cancer Registry is in collaboration with institutions in the world. And Vietnam National Cancer Control Program and Cancer Registry are involved on studies at the ministry level and the national level. Ongoing researches are research on epidemiology, diagnosis, treatment of common cancers in Vietnam, new advances in diagnosis and treatment of some common cancers, new advances in diagnosis and treatment of breast cancer. In the State of Oncology in Indonesia meeting April 2018 in Hanoi, they planned studies which are now ongoing and are also future studies. cancer registries involved in cancer surveillance, epidemiology, mortality, survival, researches in biobank, new technology in screening, biology markers in early detection, clinical trial studies, and studies on cancers in Indo-China countries, and hopefully now in all countries under AOS. Thank you. Cancer registries measuring progress, targeting action.
Mr. Chairman, good afternoon, ladies and gentlemen. I'd like to talk to the National Cancer Control Program in Korea. Korea is one of the very successful countries in recent 30 years of cancer control. From now on, I will show you the example of a Korean case, and these slides were provided by Professor Min Kyung Lim and Keun Young Yu at National Cancer Center. Since 1983, major cause of death became cancer in Korean society. CVA and heart disease also gradually increasing with slow rate. The Korean government's cancer control policy was started by Ministry of Health and Welfare when it formulated a plan to establish the National Cancer Center in 1989. In 1996, the government initiated a comprehensive 10-year plan for cancer control, and the third 5-year plan for national cancer control has been launched in 2016 with a comprehensive evaluation on previous work during the first and second term. Cancer control comprises mainly 4 components: primary prevention, early diagnosis, cancer treatment, and palliative care. So the first term was building infrastructure and capacity building initiated by National Cancer Control Act and Plan. And National Cancer Control, Cancer Registry and Statistics Expert Institute or organization, and funds for research and program operation. Actually, the purpose of NCCP was reduction of cancer burden by reducing incidence and mortality, hence increasing survival. NCC has 13 regional cancer centers all over the nation in order to decrease disparity in medical accessibility. They had financial and technical supported by the central and local government. Nationwide center cancer registry is also very important in Korean, started in 1980. The National Cancer Registry helped us to calculate cancer statistics like incidence, survival, and prevalence. NCC provide cancer information services through webs, knowledge TV, social media, call center, educational materials-based media, books, leaflets, guidelines. And recent progress of national cancer control activity in Korea. In Korea, with the initiation of the third 5-year plan for national cancer control in 2016, strengthening activities for primary cancer prevention, focusing on reducing cancer incidence caused by the avoidable risk, has been highlighted and emphasized as one of the strategic goals of the plan. In 2006, based on the knowledge and evidence from systemic reviews and expert consensus, 10 calls for cancer prevention and its practical guidelines were developed and disseminated. And this year, we had modified 2 action calls among 10 action calls of cancer prevention, according to expert consensus with the newly suggested evidence and political decision for public advocacy. The code for moderate drinking was changed to avoid alcohol consumption for cancer prevention, and vaccination against HPV was added to the code for vaccination against HEBV. We suggest the practical guidelines for prevention of 10 major risk factors of cancer development. For example, infection, weight control, smoking, drinking, diet, physical activity, health examination, and occupational risk. And the public campaign like Cancer Prevention Day, mass media campaign, offline campaign, dissemination of campaign materials. As one of the major cancer prevention measures, tobacco control has been highly prioritized in Korea, even if comprehensive law or regulation of tobacco control has not been established yet. With the ratification of WHO framework convention on tobacco control by Korean government, tobacco control activities such as levying cigarette tax, expanding restorative designated smoke-free areas, comprehensive campaign and education on harmful effect of tobacco use, and restriction of advertising sponsorship and promotion from tobacco companies has been further uh, accelerated. Due to tobacco control activities by government and expert institute, including National Cancer Center, the mass smoking prevalence has been decreased to 39.6% in year 2010, even if it is still high when it compared to the data from other OECD countries. Infectious agents such as HPV, H. pylori, and CS has been considered as important contributors of cancer development in Korea. The universal HPV vaccine program that has run since the early 1980s has shifted the risk toward intermediate endemicity, and it has led lowering the risk of liver cancer in Korea. In PEP model, 6 stages of health behavioral change, which is unaware of each, unengaged by each, deciding about acting, decide not to act, decide to act. Acting were considered for practicing of each code for cancer prevention. As a result of campaign and public education on cancer prevention, the percentage of those who know that cancer is avoidable and who aware 10 codes for cancer prevention has been increased from 53% and 46.5% in 2007 to 66 and 68 in 2016, respectively. Organized national cancer screening was managed by two systems depending on cost coverage. That is lower 50% of income level, and Medicaid is by National Cancer Screening Program without payment, and under 50% of income level, National Health Insurance Cancer Screening Program from NHI beneficiaries. Now the screening program was revised and implemented in 2016, starting by major 5 prevalent cancers, and the stomach, age over 40 every 2 years with gastro endoscopy and or upper GI, and liver over 50 with high risk groups every 6 months by liver sono and alpha fetoprotein. And for colorectal over 50 years of age, every 1 year, FOBT, if positive, colonoscopy or DCB. And for breast, over 50 years of age, woman, every 2 years, mammography and the CBE. And cervical cancer over 20 years of age, woman, every 2 years, pap smear was recommended. And the National Cancer Screening Guidelines were revised, and lung cancer was added later for every 1 year, or low-dose lung CT for smokers aged 55 to 74 with 30 pack year or above. Participation ratio in NSCP and CSP by year was surprisingly increased each year since 2002 until 10 years, around 2011 to 2012, shown in this graph. In case of a cervical cancer screening program in Korea, we can see stage shifting effect by national cervix cancer screening in Korea. So the invasive cancer become less and the carcinoma in situ is increasing, shown in this figure. And breast cancer incidence pattern in Korea is unique in age distribution. Peak age is below 50 and popular in young age women, compared to those in Caucasian and Singapore in Asian. Overall mortality rate of breast cancer may increase for a while and show a gradual decrease in the future, which will start from the young age group. The coverage of cost by insurance is very high, so the 95% of medical cost is covered by NHIC, and additional support for medical costs among cancer patients is low SES group or diagnosed by NCSP. So healthcare system for cancer patients is one of the best worldwide. Even palliative care was initiated at the third stage, and the first part started in 1996. Fostering program, and the second plan, hospice unit designation by Ministry of Health and Welfare, and the hospice inpatient payment by NHI. And third plan was starting year 16 to 20, and home hospice pilot program and shared care pilot program was added. Current status of palliative care institutions is expanding year by year and with more beds. Through those control periods, cancer statistics was changed with almost 110,000 for men and 100,000 for women each year. The number was increasing since 1999 to make a plateau in 2011. Now the age standardized rate become less every year. Breast major cancer is also changing. Breast prostate colon cancer is increasing as in advanced nations, and the breast and colorectal cancer is particularly increasing. 5-year survival rate is also increasing, measured by 5-year periods. Then early detection and development of treatment strategies has contributed. International comparison shows the best results compared to other developed nations. And the current and future challenges of national cancer control in Korea. Third term of NCCP began 2016. The aim is through cancer surveillance and quality assurance and precision medicine and supporting survivors and research planning and implementation to decreasing mortality and increasing survival rate. There are challenges of the national cancer screening program. By increasing the screening rate, we have to evaluate and improve quality of screening and by modifying the pitfalls like overdiagnosis and evaluating the effectiveness of the screening program and assessing the cost effectiveness. And this is the example of pilot project for lung cancer screening nationwide. and low-dose CCT screening reduces 20% of mortality compared to routine chest PA. We also have a supporting system for survivors, healthcare, social rehabilitation, primary prevention of secondary primary cancer. There are regional comprehensive supporting center for cancer ongoing. And also cancer big data initiatives for surveillance is going on, merging whole data from the uh, web sources. Outcome research is also very important for cancer control activities. There's a network formed from various data suppliers. Korea is one of the very successful case of national cancer control. And now we are enhancing more efficiencies and cost effectiveness and more attention to the survivors and outcome researchers. And our effort to overcome and conquer cancer will be going on continuously. Thank you for your attention.